Chest trauma. Chest trauma is a common condition seen in A&E and needs evaluation and management of this condition. Basic principles of the trauma management are applied, and these are used for the primary evaluation aimed at detecting and treating immediately the life-threatening condition, followed by a detailed secondary survey. So the primary survey is aimed at identifying the immediate life-threatening injuries and consists of A. the airway management and cervical spine care, B. Is the breathing and ventilation, C. for circulation and control of hemorrhage, D. for disability and neurological state, E. exposure and environmental control. So one has to identify the immediately life-threatening injuries, which include tension pneumothorax, massive pneumothorax, open pneumothorax, cardiac tamponade and flail chest. Airway maintenance of the cervical spine, we need to establish the airway using the basic life support maneuvers, simple venturi, mask, suction, nasopharyngeal tubes, oropharyngeal airways, intratracheal intubation, or rare emergency cricothyroidotomy. The cervical spine is immobilized if the nature of the injury includes the significant impact or the fall until possible, to exclude the instability with lateral C-spine X-ray. Breathing and ventilation, check the ventilation by looking at the chest expansion, auscultating from the breath sound and monitoring of the O2 saturations and blood gas where appropriate. Causes include of inadequate ventilations, which include the immediate management are the upper airway obstruction, malplacement of the intratracheal tube, pneumothorax, haemothorax, massive lung contusion and flail segment. Then comes the circulation and control of hemorrhage. The signs of hypovolemic shock include confusion, pallor, tachycardia, tachypnea and oliguria. If the patient access is difficult, place a large lumen catheter into the femoral vein or perform the saphenous vein cut down. Fluid resuscitation is aimed at expanding the intravascular space and may initially be titrated against the pulse, blood pressure and later against the urine output and central venous pressure. Cause of the circulatory collapse include the cardiac arrest, hypovolemia, obvious bleeding, side occult, fracture femur, pelvis, intra-abdominal bleeding, pneumothorax, cardiac tamponade, cardiac contusion, aortic dissection. Next is the disability in neurological state, the crucial in evaluation of the head and spinal injury. This is less important to cardiothoracic surgeons. Exposure, examine the patient swiftly but carefully for the evidence of penetrating blunt trauma. Penetrating wounds below the fourth intercostal space may well have crossed the diaphragm, raising the spectrum of the abdominal injury. Secondary survey, this is more detailed and a complete clinical examination aimed in elucidating some form of basic history and identifying and managing the life-threatening conditions, which include rib fracture, flail chest, pulmonary contusion, simple pneumothorax, blunt aortic injury, blunt myocardial injury. The first line of investigation performed once on the primary survey and management is established include the chest X-rays for cervical spine and pelvis is indicated, transthoracic echocardiography if pericardial effusion suspected, CT if there is suspicion about the injury to major thoracic structures and the patient is hemodynamically stable, aortography if the aortic injury is suspected. The emergency thoracotomy can be performed in the cases of the penetrating trauma, where all possible thoracotomy out in the operating room should be avoided as equipment, sterility, personnel and all are less than optimal. Indication of thoracotomy on site include the cardiac arrest, imminent cardiac arrest after penetrating trauma, cardiac tamponade in the setting of the penetrating trauma, limited role in the cardiac arrest in the setting of blunt trauma. Incision. This approach is dictated by the available expertise. Do what you are able to do and the equipment. There may not be the sternal saw or any description, much as the nature of the injury. The options are median sternotomy, First, excellent exposure of the heart, both pleural cavities, hilum, but dependent on availability of the external saw and suitable power source. Anterior thoracotomy, very fast and can be performed using just a scalpel and can be extended to improve what is very difficult, very limited access to the pericardium and ipsilateral pleura. Difficult to carry out internal cardiac massage through the incision. Bleeding from IMA can be problematic, and bilateral extended anterior thoracotomy or clamshell fast needs heavy scissors to divide the sternum in addition to scalpel. Excellent access to mediastinum and both pleura. Significant morbidity of the wounds of the survivors. Subxiphoid approach. Fast but limited access to the pericardium. Findings include the cardiac tamponade is commonest finding secondary to the right ventricular laceration and more commonly in RV laceration, occasionally injury to the coronary vessels or great vessels. The ventricular septal defect is the commonest intracardiac injury. Procedure. The ventricular lacerations are repaired with plagirate Teflon 30 Prolene sutures, taking care to avoid arteriogenic trauma to the secondary coronary arteries. Atrial lacerations are simply oversewn. The coronary artery injury, gross septal and valvular defects may require cardiopulmonary bypass. Survival. The survival following the thoracotomy for the cardiac arrest after penetrating trauma is 10%. Next is emergency thoracotomy in the operating room. This is the optimal place to perform emergency surgery. If the clinical condition permits, the patient should be transferred to the theatre immediately. It becomes clear that thoracotomy is indicated. The delaying transfer to insert the additional invasive monitoring simply increases the likelihood of performing thoracotomy on site. Indications: hemodynamically instability following penetrating chest trauma. As opposite, think carefully before positioning the patient in any way other than supine. Laparotomy is not infrequently needed. The blunt trauma may cause the tracheobronchial injury, uncommon approximately in 0.5% of trauma cases, immediately life-threatening. Penetrating trauma secondary to stab or gunshot wound can cause tracheobronchial injury. The blunt trauma or the dashboard injury secondary to unrestrained motor vehicle passenger and the sudden hyperextension of the neck. 80% occurs in 2.5 cm of the carina, frequently associated with other major injuries. Presentation include dyspnea, respiratory distress, hoarseness, and dysphonia. The surgical subcutaneous emphysema is common. Pneumothorax is approximately 50% cases of the hemoptysis in less than 25%. The chest radiograph should be done, and it may show the disruption of the trachea and the bronchial air column. Compie sign. CT thorax is assessing the rest of the thorax. Contraindicated in hemodynamically unstable patient or those with unstable airway. Bronchoscopy is diagnostic. Secure the airway, consider intubation. A double lumen intratracheal tube is contraindicated in the distal tracheal and the proximal main stem bronchus. Bronchoscopy will provide the accurate assessment of the extent and location of the injury, allowing planning for the surgical repair. Primary surgical repair almost always indicated. The proximal tracheal injuries may be appropriate via the cervical collar incision. The distal trachea, carina, and the right main bronchus may be approached via the right posterolateral thoracotomy. If the left main bronchus, via the left posterolateral thoracotomy. Clean injuries with no devascularized tissues may be primarily sutured, and devascularized tissues requires resection with end-to-end anastomosis of the airways. Complications include anastomotic descent, fistula formation, tracheoinnominate artery, tracheoesophageal anastomosis stricture, bleeding, infection, nerve damage. 75% of the patients with tracheobronchial injuries secondary to the blunt trauma die before arrival to A&E department. Over 90% of the long-term survivals in those admitted alive. Blunt trauma to the chest wall, mechanism of injuries, motor vehicle accidents, falls from the height, blast injuries, assaults and child abuse, usually an indicator for other severe intrathoracic injuries. Contusion, hematoma. Bleeding from the skeletal fractures may produce significant hematoma. Management is observation of these is usually adequate, may require evacuation of hematoma and ligation of bleeding vessels. Intercostal drain insertion is common after blunt trauma. Typical site of insertion is fifth intercostal space and mid-axillary line. It may extend anteriorly to the anterior axillary line. And prep and drape the skin, infiltrate the site with the tube insertion, local anesthetic uh, anesthesia at all layers down into the parietal pleura. 2 centimeters transverse incision is made intercostal space, dissected bluntly. The pleura is opened over the superior aspect of the rib. The finger is placed into the pleura to make sure there is no adhesion. The chest tube is then passed bluntly into the pleural space, being guided superiorly for pneumothorax and basally for haemothorax. The drain is secured with a strong suture and tube is placed using underwater seal. Open pneumothorax critical if wound is larger than 2 centimeters. 3 side taping with occlusive dressing, chest drain insertion, local wound debridement and treat underlying injuries. Fractures can happen after the chest trauma. Rib fractures, commonly 4 to 9 ribs, are commonly fractured associated with the underlying lung, pleural, bronchial, or cardiac injuries. Lower rib fractures are associated with renal, hepatic, or splenic injuries. Fractures of one first rib indicates major trauma. Management of the rib fracture include adequate analgesia may require the regional nerve block. Epidural provides the effective anesthesia with minimal complications. Flail segment caused by the 4 or more ribs being fractured at least 2 places leads to the paradoxical respiration. Diagnosis easily made by observing this chest wall, often underlying pulmonary contusion. The management include the adequate analgesia. Significant respiratory compromise may require mechanical ventilation. Surgical fixation may be indicated for cosmetic deformity, thoracotomy, or other reasons, and failed weaning of the ventilation, judicious fluid administration. External fractures. Sternal fracture usually upper or the middle third of body of the sternum, secondary to the motor vehicle accident, presentation, point tenderness, edema, deformity of the sternum, investigation, lateral chest x-ray is diagnostic, management observation for associated cardiac injury and pulmonary injury, surgical fixation of the sternum is rarely indicated. Next topic is the clavicular fracture. Presentation is point tenderness, deformity, and crepitus. Chest radiograph is usually diagnostic. Clavicular dislocation is rare. Management usually non-surgical. Blunt pulmonary trauma. Common injuries seen with bone blunt and penetrating wounds, commonly seen with the motor vehicle accidents and fall from the great height. Presentation include dyspnea, tachypnea, hemoptysis, cyanosis, hypotension. Chest radiograph may show patchy infiltrate. If severe infiltrate may involve entire lung, CT scan is more sensitive in demonstrating these changes, may lead to ARDS. Management is supportive oxygen therapy, adequate analgesia, chest physiotherapy, endotracheal evacuation and ventilation may become necessary, and cautious administration. The pulmonary lacerations. Pulmonary lacerations most commonly following the penetrating chest trauma. These are associated with hemothorax, pneumothorax, and pneumothorax. Extensive pulmonary lacerations are seen following the high-speed motor vehicle accidents, often centrally located, disrupting to large vessels and major bronchi. Management include the peripheral laceration may be over soon or excised, and they may heal following the chest tube insertion. More excessive and the central lacerations require surgical repair more urgently. The control of the hilum is adequately prior to the repair. Bronchial and vascular injuries are repaired. Lacerations is usually left open with appropriately placed chest tube. Traumatic pneumothorax, the direct lung injury from rib fractures to the rapid deceleration may be secondary to the rapid rise in intrathoracic pressure against the closed glottis cause the rupture of the distal alveoli. Presentation, dyspnea and chest pain. Examination reveals the hyperresonance to the percussion and diminished or absent breath sounds or auscultation. Attention pneumothorax is life-threatening, and in addition above may present with subcutaneous emphysema, mediastinal shift, and acute respiratory distress. Hemodynamic instability. Immediate chest decompression is indicated and performed by placing a wide bore needle into the pleural cavity. in the secondary intercostal space and the midclavicular line. Definitive management is chest tube insertion in fourth or fifth intercostal space, mid-axillary line, directing the chest tube anteriorly to superiorly, and thoracotomy is rarely indicated. Haemothorax causes include the chest wall injury, lung parenchymal laceration, bronchial artery injury, intercostal vessel injury, major thoracic vascular injury, and the chest radiograph is diagnostic. Treatment includes tube thoracostomy, inserting the wide bore cannula at least 36 FR tube in fifth or sixth intercostal space in the mid-axillary line, and directing the tube posteriorly. Bleeding ceases in 80 to 90% of the cases. Indications for surgery: immediate blood loss of more than 1 liter, or bleeding continues in excess of 200 mL per hour for 4 or more hours. Blunt trauma, esophagus and thoracic duct are rare. Thank you.